Hi, Andrew Penn back again. This time talking about ADHD treatments, particularly pharmacology. So we're going to review the available medications for ADHD, both stimulant and non-stimulants, and compare what is the difference between all these different stimulant preparations that are out there. And then finally plotting out what is a reasonable medication course for treating ADHD. So really we've got two main buckets of medications to think about. We've got stimulants, which generally are considered first-line treatments unless there's a reason not to. And those broadly break into amphetamines and methylphenidate. And then we have the non-stimulants, which atomoxetine, the alpha-2 agonists such as guanfacine, and certain antidepressants such as bupropion and some of the tricyclic antidepressants, which largely work on norepinephrine and to some extent a little bit on dopamine, would be the buckets that we have for the non-stimulant medication choices. Now, when you start looking at all the different ADHD medications that are out there, it can feel a little overwhelming. But when you look closely, I got a tip for you. They're all pretty similar. They're similar in what they are at their base. So most of them are methylphenidate or they're amphetamine. Now, where they differ is in how they are formulated. So sometimes they are immediate acting, sometimes they are long acting, sometimes they're intermediate acting. And then each of the different types of longer acting drugs have different mechanisms for releasing the medication over time. Of course, they all give them different brand names, so it makes it sound like there's all these different things, but it's a little bit like this meme here that they are more alike than they are different. But we'll go over that in a minute. So this is available for you on the website, and I've gone ahead and put in red boxes. What are really my go-to meds here? So this first page here are the methylphenidates. And so Ritalin is the brand name of the classic methylphenidate drug, and that's been around, as you can see, since 1955. It's been around for a long time, and is also referred to as methylin. Just to make things more confusing. And so this is the immediate acting drug and typically is dosed anywhere between 5 to 20 milligrams 3 times a day. So lots of different, wide range there. You have the intermediate acting drugs, so the Ritalin SR or methylin ER. And then you have the long acting meds, which I really like a lot more. So Concerta is probably the classic of this group here. So this is methylphenidate in a long-acting all-day formulation. Now, if you notice the available strengths, the numbers are kind of wacky. So it's 18 milligrams, 27 milligrams, 36 milligrams, and 54 milligrams, which is just an odd set of numbers, but that's what they came up with. And these are typically will last sort of 10 to 12 hours. So as long as this is taken first thing in the morning, often we'll get somebody through the whole day. Now, when we turn our attention to the amphetamines, so this so we've got, if you go back and think about our original talk on pharmacology, you remember enantiomers. So there's a racemic mixture is when you put the right hand and the left hand molecules together into one pill. If you have an isomer of that, you would take just one side. So dextro means right. So this is the right-handed amphetamine molecule for dexedrine. So you can see, been around for a long time. And then Adderall is mixed amphetamine salts or racemic amphetamine salts. So that's the right amphetamine and the left amphetamine put together into one pill. And so it's actually, left amphetamine and dextroamphetamine. So levoamphetamine, dextroamphetamine. And they put those together into the same pill because they have different durations of action. And slightly different effects on the receptor sites. But this comes in an immediate acting, which generally lasts sort of 5 to 6 hours. They have it up here as 8. I rarely see it last that long. And then the Adderall XR, which is the extended release, which typically, again, is an all-day pill. And you're gonna give somebody that at the beginning of the day, once a day, typically, and that should get them through the entire day. Newer on the market is Vyvanse, which is lisdexamphetamine. That's kind of a mouthful, but this is interesting in that they took a lysine molecule, attached it to the amphetamine molecule, which makes it so if you don't orally ingest it, that lysine molecule prevents the drug from having an effect. So in essence, if you snort this or inject it, so take it through a non-oral route, that lysine molecule blocks that drug from working. And then, as I mentioned earlier, there are the non-stimulant medications. So the alpha-2 agonists like clonidine, guanfacine is another alpha-2 agonist. And then we have Provigil or modafinil, which is a histamine agonist drug, which is technically on label for narcolepsy, but is sometimes used in off-label capacity for ADHD. You have atomoxetine, which is marketed as Strattera, which is a norepinephrine reuptake inhibitor, so not unlike bupropion. In fact, the backstory on Strattera was that supposedly it was a failed bupropion competitor drug for depression. It failed on the depression in the depression department, but Eli Lilly got the idea to test it out for ADHD, and it was found to have some attention improving effects. So that's what it got marketed as. And then we have bupropion, which, as I mentioned before, is a norepinephrine reuptake inhibitor, which comes in extended and shorter acting forms. So let's turn our attention to methylphenidate. So as you know now, methylphenidate is a drug with many different names depending on its formulation. So Concerta being the most common one, Ritalin being the other brand name that people are familiar with. And then there's dexmethylphenidate, it's a mouthful, which is the right isomer of that drug. So that dex refers to right, and so that's Focalin and Focalin extended release. So methylphenidate, regardless of its formulation, does the same thing when it gets to the synapse. It has the same mechanism of action, which is to inhibit the reuptake of dopamine and norepinephrine. So just like an SSRI inhibits the reuptake of serotonin, which keeps more serotonin in the synapse, meaning it's more likely to get over to the other side of the synapse and hit the receptors, this does the same thing, but for norepinephrine and dopamine. So it is an inhibitor of both of the reuptakes of those two neurotransmitters. So methylphenidate comes in various different forms, as I mentioned. So Ritalin or Methylin is the shortest acting. And the pros to this is that because it's shorter acting, you can take it later in the day. It's less likely to keep you awake at night. The downside is you have a lot of up and down. So people sometimes will feel like they're crashing as a stimulant wears off, which means they can feel more irritable, they can feel tired, they can feel their attention starting to wane. And if you're doing that sort of up and down several times a day, that can be kind of exhausting. And honestly, it's hard for people to remember to take things 3 times a day, especially a population that by definition has problems with their attention and concentration. And there is this thought that shorter acting stimulants have more potential for abuse risk because you're constantly kind of hitting those reward circuits. And so the conventional wisdom has been that the longer acting medications have less abuse risk. So the medium acting, you get about 5 to 8 hours out of, and this is the Metadate and extended release Ritalin. Still some insomnia risk, but less so as long as you don't take it too late in the day. I usually tell people, look, if you've forgotten to take your long-acting stimulant after lunch, don't take it that day. You're just going to have to get through that day with not so great attention, because if you take it, at 3 o'clock, there's a good chance you're going to be up late at night and not able to sleep. And then finally, Concerta is that long-acting methylphenidate. So as you can see, it's got a mixture of both a little bit of immediate release, so about a quarter of it is immediate release, a quarter of the total dose, and then the remaining is extended release. So the nice thing about this, you take it once a day in the morning, you forget it, it has this kind of nice soft onset, and then a gentle come down. So as long as you take it early enough in the day, this usually works quite well. And all of the stimulant medications, in addition to causing insomnia, can cause some suppression of appetite. So if somebody is noticing they're losing weight when taking a stimulant medication, I usually counsel them to have a very hearty breakfast first thing in the morning before they take their stimulant medication to make sure they get enough calories for the day. So this is the Concerta mechanism of action. This is interesting. So kind of geeky drug technology here, but this is called an osmotic releasing oral system. So you can see the capsule is actually a plastic little tube. It's a little plastic capsule, and you need to warn people of that because it will come out in your poop. It will not dissolve, and people are always will call you and say, I don't think I'm absorbing it because I saw the plastic thing in the poop. And that's normal, because you can see what at the top of the pill there is actually a little opening that's drilled in the top. And what happens is that fluid will be absorbed from the gut lumen and actually cause the drug to push out of that top through osmotic pressure. So it's kind of cool technology, and this allows the drug to be released slowly over time. Now let's turn our attention to the amphetamines, which are the other major class of the stimulants. So we have the mixed amphetamine salts, which are about 3/4 dextroamphetamine and 1/4 the levoamphetamine, or the left-hand amphetamine salt. And we've also got dextroamphetamine, which is just the right-handed molecule. And we also have this, this Vyvanse, which is a little bit of an outlier. So amphetamines work by not only preventing the reuptake of dopamine, just like methylphenidate does, but it also causes dopamine to be pushed out of the vesicles. So we covered this in the first lecture when we talked about drug mechanism of action, that some drugs like amphetamines actually push the neurotransmitter out of the vesicle. And in the case of amphetamines, it's dopamine that's going to be released, pushed out through those vesicles. But you also have reuptake inhibition of norepinephrine. So in the same way that methylphenidate does this, so does amphetamine. Yeah, so you're doing a combination of things. You're keeping more norepinephrine in the synapse by preventing the reuptake. You're preventing the reuptake of dopamine, and you're actually pushing dopamine out into the synapse. Now, amphetamines, like methylphenidate, come in different preparations, which are largely based on their duration of action. So the very shortest acting amphetamine preparations are the like Adderall IR, immediate release, or dextroamphetamine. And so these, again, have the benefit of being less likely to cause insomnia because they don't last as long, which gives you some more flexibility in dosing. I will sometimes use I tend to lean primarily on the extended release because you're more likely to get good results if the person takes it every day. But you will sometimes have patients where the drug will wear off for them before they're done for the day. So this is common with like college students that have an evening class, for example, but you don't want to have them not be able to fall asleep that night. So if somebody's saying, well, you know, my Concerta or my Adderall XR is wearing off by about 5 o'clock, but I've got this 6 o'clock class that goes until 9 a couple of days a week, I might give them a small amount of short-acting Adderall immediate release for those days. So you can kind of top up, if you will, in a more flexible way. But again, same problems with the immediate release methylphenidate is that you can have that crash, you can have the problems of forgetting to take it, and potentially this is a more reinforcing drug. So there are these extended release formulas such as the Adderall XR and the dexedrine Spansouls, and there's a new one called Mideas. And so they're all essentially variations on a theme. It's kind of like the boys from The Bachelor. And again, nice thing is once a day, you forget it, it's in your system. And as long as you take it early enough in the day, you're less likely to have problems with insomnia, but you do need to pay attention to your food intake. And then dexamphetamine, if I can say it, is Vyvanse. And this, as I said before, is a combination of dextroamphetamine and lysine. So that lysine actually makes the dextroamphetamine inactive until it gets into the gut. The lysine is cleaved off by the gut enzymes, and then you have dextroamphetamine in your system. So it's essentially a prodrug, and it's a fairly long-acting drug too. It's good for about 14 hours. So again, once a day in the morning, and kind of forget about it. But if you take Vyvanse and you chop it up and you try and snort it, it won't do anything because it's not exposed to those gut enzymes that are going to cleave the lysine off. Now, what about non-stimulant alternatives, which you may want for a number of reasons? The biggest one being if you have somebody who is at risk for substance abuse, but you will also have some patients that say, I don't want to take a stimulant. So you've got bupropion in the same standard dosing that you would use for depression, so 150 to 450 milligrams of the extended release is reasonable. You've got atomoxetine, which is, like I said earlier, also a norepinephrine dopamine reuptake inhibitor, which allows for more norepinephrine and dopamine to be available in the synapse. You've got clonidine, which is largely an alpha-2 adrenergic receptor agonist. You've also got guanfacine in immediate release in the form of 10x and extended release in the form of a drug called Intuitive, which is also an alpha-2 adrenergic agonist. And both of these are increasing the postsynaptic activity at norepinephrine reuptake. Norepinephrine receptors. So you get more norepinephrine activity happening as a result of these two drugs. So here's a good algorithm, which will also be on the class website for you to possibly print out and keep with you, that lays this out very nicely. This is from the Carlat report, and talks about, well, if you've got comorbidities such as bipolar disorder, you're going to want to have a stimulant, but only with a mood stabilizer. If you've got somebody with psychosis, generally you want to avoid stimulants. And if you've got somebody with depression, you're probably going to add an antidepressant as well, because you really want to get that well controlled first and make sure that they're still having problems with attention even when they're not depressed. And bupropion, as they point out here, you might get kind of a twofer out of that. If somebody is a good candidate for stimulants, then there's a couple different ways that you can do this. Like I used to start with a short-acting stimulant and then have them tell me what that total dose was, and then combine that into a long-acting. In more recent years, I actually started going to just long-acting right out of the gate. And I would usually give people kind of a range. Now, your different clinic sites may have different ways of doing this, but if I felt like the patient was not at risk for misusing the med, I would often give them, say, something like Adderall, 10 milligram extended release, and I would give them 10 milligram capsules. And I would say, you can take up to 40 milligrams of this, no more without contacting me first. And the way I want you to do this is I want you to try a couple of days at 10 milligrams. You may not notice anything. So then you say, well, I'm curious what 20 milligrams will do. So you take 20 milligrams for a couple of days in a row. And you start thinking, well, I'm starting to feel something. I wonder what 30 milligrams is like. And so you go to 30 milligrams for a couple of days. And you go, wow, is this what other people's brains are like? This is amazing. I can actually get stuff done, and I'm not getting distracted, and I know where my phone and my keys are. I haven't lost them for 2 days. This is incredible. I love this. I wonder what 40 milligrams is like. And they take 40 milligrams. They're like, oh my God, that was too much. So they overshot that mark on that inverted U-shaped curve, and their attention and focus actually started to decline. And so what I tell people is, if you notice that, go back to the previous notch and then tell me what the sweet spot was. So they'll send me an email or call me and say, you know what, Andrew, 30 milligrams was really was magic. 40 was too much, but 30 worked great. And I'll just convert it to a 30 milligram pill and carry on from there. So you can do that with Adderall. You can do that with the methylphenidate, Ritalin type drugs. And then finally, for your group of people who stimulant is contraindicated, so these are people with cardiovascular issues. So I should point that out, that if somebody has a history of an MI, or they have a history of arrhythmias, you're going to want to get cleared by their cardiologist before you start this, because there is the potential of causing tachycardia, hypertension, and arrhythmias with stimulants. So you want to get a collaborative agreement with your cardiology colleagues. And also, if somebody has a history of stimulant use disorder, either amphetamines or cocaine, you want to be really careful with starting a stimulant. And so your options here would be something like atomoxetine. If they're also depressed, you could use bupropion. Interestingly, if somebody has nightmares along with PTSD and ADHD, you might think about clonidine, because that, in the same way that prazosin is sometimes used to help with nightmares, some of these noradrenergic hypertensive meds can also help with nightmares. And so something like guanfacine or clonidine might be indicated there. And this is sort of repeated in this sort of similar layout here, but with more specific dosing. And then again, your population that is less likely to abuse stimulants. So in summary, ADHD meds are essentially divided into two buckets, even though there are lots of different names of the different medications. They really divide up into stimulants, which is the large portion of them, and then the non-stimulant medications, which are often used for other things such as depression and hypertension. And in general, you want to lean more on the longer acting medications, especially if the person can be disciplined about taking it at the beginning of the day, because you want to avoid the insomnia that happens if you take it too late in the day. And so really, I have to say that treating ADHD is probably one of the most satisfying things that I find clinically, because these meds work great. And when you find the right drug and the right dose, it's really quite incredible how well somebody can improve. And I've seen people's lives really markedly get better as a result of treating ADHD. So really the trick is finding the right drug, the right dose, and the right duration of action for each individual patient. And I hope this is helpful for you. Thanks.